Slides, Dr. Nath.
Thank you. Well, thanks very much for the introduction and for inviting me to your conference. I really enjoyed the two presentations. Let me just go to the first slide here. Okay, maybe I can't. Okay, well, I do have a disclosure, and my disclosure is that I'm not an anesthesiologist. I'm just a neurologist. But I have tremendous respect and regard for you and your profession. I've divided my talk into a little bit of introduction about pandemics and coronaviruses. I'll talk about neurological complications, and I'll discuss a little bit of pathophysiology because I think that'll have a lot of implications on how you treat these patients and how you manage their anesthesia. So I want to start with this quote from Sir William Osler, and at that time he was the chair of internal medicine at Hopkins. And he gave the keynote address in 1896 to the American Medical Association. And he said that humanity has but three great enemies: fever, famine, and war. I guess if he gave that same address today, instead of famine, he would probably say climate change. Of these, by far the greatest, by far the most terrible is fever. And that is really infections. And that is so true today. As you can see, infections wipe out more people on this planet than all the wars and famine put together. In fact, it is said that that's how human evolution has taken place. You have a wave of infection comes, wipes out a lot of people, few remain on the planet, they repopulate it, and then comes another wave of infection and wipes out a huge population. And so we're seeing that today, even in the modern era. And it has social consequences. And some of you might remember the AIDS pandemic. I mean, it's still there, but in the 80s, it caused a lot of social unrest. People were dying in large numbers. And this is the Washington Mall. And every year there would be an AIDS quilt, and each piece of fabric represented an individual who had died of AIDS. Eventually, the quilt became so big that it couldn't be put on the Washington Mall any longer. You fast forward 35 years, and this is at the time of inauguration of our current president. Same Washington Mall. This time you have flags posted there for each individual who has died of COVID. At the time of the inauguration, there were 440,000 flags. Today, the official number of people dead is 700,000. And unofficially, we think that there are about 900,000 people who have probably died. And the rate of death even today is about 2,000 deaths per day. So this pandemic is far from over, and we're going to see a lot of consequences of patients who survive from this infection. If you look at coronaviruses, there are 7 human coronaviruses, 6 listed here. Each one of them causes neurological complications. So it should come as no surprise that SARS-CoV-2 also has lots of neurological manifestations, although it does not get recognized till later in the pandemic. And that's been the case with all pandemic infections. We get focused on the primary organ that's involved, and we forget that other organ systems can be affected, and particularly the brain. If you look at the complications from COVID and that affect the brain, you can divide them into 2 major classes. The first is para-infectious, and those are the ones that occur during the acute phase of the infection. And then the other are the post-viral syndromes, and those are largely immune mediated. This inverted triangle here because just to show you that the ones on top are more common, the ones at the bottom are less common. But I'll go over some of these in a little bit more detail. The other thing that is, I think, very important for you as anesthesiologists is that those individuals who have had COVID in the past, they may have some spontaneous recovery, but once they get past 3 months, or in this study, past 5 months, they just do not recover. They have persistent symptoms. And the more severe their illness, the more likely they are to have persistent symptoms. So the one on top here is individuals with severe infection, the middle is moderate, and then mild. But even mild infection is very significant because almost here about 25% of these individuals continue to have persistent symptoms all the way to 1 year. Interestingly, it's more in women compared to men, and I think that is because most of these are immune mediated, and most immune mediated disorders are more common in women. So what are these manifestations? They vary from individual to individual. Certainly, so they are, we've divided them into 4 subgroups, but they overlap with one another. And there is a group that has cognitive abnormalities, and they complain of brain fog. They have mood and sleep disorders. So anxiety, depression, first-time psychosis can occur in some of these patients. Anxiety can be actually quite phenomenal. Seen individuals that never had any psychiatric manifestation, all of a sudden they can't control their anxiety any longer. Exercise intolerance, and they call it fatigue, but really what they're complaining of is exercise intolerance. And so I talked to one cardiologist, and she said that since she had COVID, now every time she even climbs a flight of stairs, she's just wiped out. She couldn't even practice telemedicine any longer. There are individuals who have dysautonomia. Again, for anesthesiologists, this is probably extremely important because these individuals can get hypotension. They can have tachycardia. And I think that tachycardia, although the patients will complain of tachycardia, they don't complain of the symptoms of hypertension. I think the tachycardia is secondary to hypertension. Some will have persistent fever, and the fever is not because of the infection, it's because of dysautonomia itself. And then the muscle involvement is also important because they can have myositis, and the CPK levels can be elevated. So for certain types of anesthetic drugs that you use, I think that's important to remember that. So one may think intuitively that all these things have to be directly caused by the virus, but I'm going to try to convince you that really is not the case. However, the reason people worry about it is because there is a massive infection in the nasal mucosa, right? And so what you worry about is that the nasal mucosa maybe, and people complain of loss of smell, maybe the virus just makes it through the cribriform plate and it can affect the brain in that way. And certainly with this other coronavirus, which is called OC43 in this animal model, that is the case. You hear these researchers from Canada, they put the fluorescent form of this virus into the nose, and these numbers represent the days after inoculation. So you can see at day 2, the virus is right here. And by day 3 and 4, it travels all the way across the brainstem. Okay. So there is only one synapse between the olfactory bulb and the brainstem. So it can go transneuronally all the way up here. If it goes to the brainstem, what you worry about is the pre-Bodzinger complex. And that is important in respiratory control, right? And close to the pre-Bodzinger complex also is the vagus nerve nucleus. And the vagus nerve innervates the trachea as well as the GI tract. So it's quite possible, at least theoretically, that the virus could move all the way from those mucosal surfaces up here into the brainstem, and certainly can come from the nose again to the brainstem. So theoretically, there's great concern that that could be happening, but the evidence for that is not as strong as we would like to see. So what is the case? If you look at the nasal mucosa under electron microscopy, you'll see that there's a lot of virus there. I mean, all these small particles here are all viral particles. So in fact, every time an infected person breathes, they throw out huge amounts of virus. Okay. So for that reason, if you wear a mask, if you don't cover your nose, it's really ineffective. But the ACE2 receptor, which is the receptor for the virus, is present on these sustencular cells, which are the support cells. It's not on the olfactory nerve itself. So by immunostaining, again, you can see these sustencular cells expressing the ACE2 receptor, but it's not on neurons and other cell types. But the concern, as I said, is that if something were to occur in the brainstem, patients can develop this condition that is called Ondines curse. And Ondines curse is a central hypoventilation syndrome because the nuclei no longer respond to changes in CO2 or pH, right? And if you lose that drive, then you have to remember to breathe. And so these patients will die in bed. And in fact, I'll show you some autopsy cases of patients whereby these were individuals who were found dead in and ended up in the New York Medical Examiner's office. So, so these are autopsies of those individuals. And so what we did was, these are formalin fixed tissues. We did an MRI scan at a 11.4 Tesla scanner. And this is the first time human brain has ever been put in such a high resolution scanner. But you can see the exquisite anatomy of the brain here. So each of the nuclei can easily be mapped. So then we made sections from each of these regions and looked at them more carefully. And what we did here is the pre-Bartzinger complex. And you can see all these brown staining cells are macrophages or microglial cells, and they're surrounding neurons. And these neurons are atrophic, okay? So let me just show you here on an H&E stain here. All these blue cells here are microglia. And in the middle is this neuron, which is really small and atrophic. So this phenomenon is called neuroinflammation. So these neurons are certainly damaged in this area. And I told you we have a select population who had died in their sleep. There were a couple that were found dead in the subway. So it is quite possible that either they had a cardiac arrhythmia or they may have developed central hypoventilation syndrome. So we tried to look for the virus at autopsy, and other groups have reported some detection, but they rarely find it. And if they do find it, it's in very small quantities. But we've done immunostaining, PCR, RNA in situ hybridization, sequencing, and we don't find the virus. At least we haven't been able to convince ourselves. It's quite possible maybe we missed it, but we certainly have looked very extensively. So if it's there, it has to be in very small amounts. Certainly there is no evidence of overwhelming infection within the brain. So you have to postulate some other mechanism. What about neuroinflammation? Okay. So there are a number of inflammatory syndromes that can occur in the brain. So the most common is acute disseminated encephalomyelitis, and you can see this ring-enhancing lesion here in the brain, and you can see a lesion here on the spinal cord. Oftentimes patients will get lesions in the brain, may not necessarily have it in the spinal cord, but I think it's still part of the same spectrum. It's important to recognize it because this is largely T-cell mediated. And so your treatment should be targeted against that. And corticosteroids would probably work, and other kinds of T-cell mediated therapies can be used. Then there's yet another process, which another manifestation that is called acute necrotizing hemorrhagic encephalopathy. This has a very classical picture here. You'll see high signal intensity lesions in the thalami, and there's bleeding there in the brain. And so they're bilaterally symmetrical lesions, and then they all spread to other parts of the brain, but they maintain a symmetry. And they're cytokine mediated. So here you would have to use cytokine antagonists, for example, ones that block tocilizumab that blocks IL-6, or anakinra that blocks IL-1. So I would think that your preoperative screening should include not only cognitive symptoms, but you should also look for spinal cord dysfunction, particularly if you're thinking of giving epidurals and so on and so forth, to make sure that there isn't an underlying problem with the spinal cord. So asking for urinary symptoms, or just examining the reflexes in the lower extremities, but measuring their strength could be actually very informative. What about children? So children have
Dr. Nath, could you unmute yourself? Sorry.
Yeah. Oh, okay. Yeah, here we go.
Sorry there.
Yeah. Okay. So in children, you can also develop a pretty profound syndrome, and that can affect multiple organs, including the brain. And we call it multi-inflammatory syndrome with COVID. And with all these children now going back to school, you can see all the ICUs have been filled up with kids. And they're going to come out with all kinds of post-COVID manifestations. And so here's an example of a child who develops a typical respiratory viral syndrome, but then goes on to develop an encephalopathy with generalized weakness. The MRI scan shows a lesion in the splenium of the corpus callosum, and there are inflammatory markers here. Right? But if you look at the post-COVID symptoms in these children, they can involve any aspect, everything from seizures to headaches, confusion, and fatigue or weakness. So what is driving these manifestations? I told you can't find the virus, and there's no evidence of viremia either. I mean, you can be sick with huge amounts of virus in your lungs and your nose, but if you look at the blood, you never actually find the virus there. So this is a group from Germany, and what they did is they looked at spinal fluid and they did single cell sequencing. And what they found was that in these patients who were subacute in illness and had neurological manifestations, they found this particular subtype of monocytes, which is a dedifferentiated monocyte. And that's a very activated form of monocyte, produces a lot of cytokines. So that tells you that the innate immune system is actually activated in these individuals. However, interferon responses are diminished. So you can see these are individuals with viral encephalitis. This is neuro-COVID here. And the line in between tells you that all the activation of the gamma interferon responses are in patients with viral encephalitis, not in the neuro-COVID. Right? And they looked for T cell exhaustion markers, and they found that all the T cell exhaustion markers are present in individuals with COVID. So you have a combination of the T cells are exhausted, the interferon responses are diminished. That means your immune responses that are important for controlling the infection are actually impaired. And what instead you have is activation of innate immune responses. That's not a good scenario, because innate immune responses are not good enough to be able to get rid of the infection. However, they cause a lot of destruction in any organ system that they go to. Okay. Because it's like blanket bombing. They don't know where the enemy really is. They just go into an organ and they just release everything they can. And once this gets activated, it's very hard to turn it around. Okay. So when you see innate system activated, you're going to see long-term consequences. So again, in our autopsy series, I can show you here in the perivascular regions, there is a lot of activated macrophages here. All these brown cells are macrophages. And we also found activated astrocytes here around the blood vessel, but we don't find very many T cells. So very few T cells. The relative absence of T cells also tells you that there must not be virus in the brain, because if there was virus, you would see largely T cells and not macrophages. And all these are present in the perivascular region. So PV here means perivascular. They're not in the parenchyma. So it just means that there's leakage, and they just sit right here, and that's about it. And the inflammation, it can also be present in the muscles. So you can see here inflammatory infiltrates here in the muscle. These, for example, this patient here presented with facial weakness, dysarthria, proximal muscle weakness, so generalized muscle weakness. Okay, so what I'm going to convince you is that almost all these manifestations can be explained by vascular injury, and that is the key feature that drives the entire clinical syndrome in these patients. There are different types of vascular injuries you can see, and so some patients will develop strokes, and here in this individual you have bilateral strokes, and they're acute strokes at the same time. Some individuals have strokes and also have occlusion of blood vessels to the kidney or pulmonary embolism. So if you see any manifestation of thrombosis, be aware that there could be multiple organ systems that are involved. Some patients can develop microhemorrhages. And here at autopsy, we can show you these congested blood vessels and a microhemorrhage here in the cerebellum. Others can develop thromboses of the venous system. So you can have here's the sagittal sinus thrombosis. So as a preoperative screening, should include the fundus of the eye, okay? Because you will see a lot of these types of manifestations in the eye itself. So I think that's critical. And if you do an MRI, make sure that you do an SWI sequence, otherwise you'll miss these microhemorrhages, and do an MRV, otherwise you'll miss the thrombosis. And I can tell you many instances of COVID patients where these two manifestations have been missed. So we did, as I told you, MRI scanning at autopsy, and here, this is from the brainstem, and then we reconstructed these images. So the advantage of doing so these are about 25 micron sections through the entire brainstem. Okay, so the brainstem alone would take us a whole weekend of continuous MRI scanning to produce these images, but the reconstruction is very informative because we looked at this one blood vessel here, and what you can see is the wall itself has a high signal intensity, which suggests that it's probably inflamed. There is a little thrombus sitting in the blood vessel here. And you can see a little microhemorrhage. It's the same blood vessel, just cut in a different plane. And you can see a little microhemorrhage over here. So you have 3 different types of pathologies in the same blood vessel itself. And so better characterize the blood vessel pathology, what you do is, one way to do that is to stain it for fibrinogen, because fibrinogen is a large protein. It doesn't get outside the blood vessels. But you can see on the spawns, what we did was, since we had these MRI images, we cut sections from these blood vessels that were very prominent. And what we found was that around each of these blood vessels, there's huge amounts of fibrinogen. It's extremely dark. And as you go further into the parenchyma, it gets lighter and lighter. So it's diffusing from these blood vessels into the parenchyma. So you can see large amounts of fibrinogen in the parenchyma here. Look at the olfactory bulb here. It's almost full of fibrinogen, right? So this person would never recover smell. The other interesting thing about these blood vessels is that what we found is that there are a lot of activated platelets. Okay. So all these brown cells here are platelets, and they're sticking to the endothelium here. And the very small blood vessels are totally occluded. So this will explain the microinfarcts that you see in some of these individuals. Okay. And for whatever reason, the pathology seems to be a little bit more in the hindbrain than in the forebrain, but not by a lot. It's still statistically significant, though. So what about these endothelial cells? What we found is, so on top is a control brain, and this is a patient with COVID. And so this is a platelet endothelial cell adhesion molecule. That's what PCAM stands for. And so you can see massive expression on the endothelial cells. And as the name indicates, it's a platelet adhesion molecule. So if this is expressed, the platelets will adhere. The platelets adhere, you're going to form thrombi. But what also found was that there's complement deposition as well as immunoglobulin deposition in these. So I think it's being driven by immune complexes. Okay. Now, what is forming these immune complexes is still not entirely clear. It's possible maybe there's some spike protein that the antibodies are binding to, and that's binding to the H2 on the receptor, or there could be anti-idiotypic antibodies. So you don't even have to involve the spike protein any longer. And those could interact with the endothelial cells and initiate the cascade. This paper from University of Michigan shows that some patients do have antiphospholipid antibodies, and they went through great lengths to show you that number one, it's almost 50% of these individuals had them, and then they took these antibodies and put them in mice, and they showed that the mice will develop thrombi. So they show you that they are of pathogenic significance. So here's our hypothesis. We think that there are these immune complexes that form that leads to activation of the complement cascade, and that then leads to these platelets getting aggregated here, and with thrombus formation. And once this forms, the blood vessels become leaky. The fibrinogen leaks in the perivascular area. And that then leads to activation of macrophages and microglia here, as well as the astrocytes. And the activated microglia then result in neuronophagia. So I'd like to conclude by saying that patients with a history of COVID may also have a large number of non-specific symptoms, and they may be due to vascular compromise, dysautonomia, brain, spinal cord, or muscle involvement. So I think that's very important for you to be aware of as you see these patients, and you're going to be seeing a lot of them for several years. Neuroimmune dysfunction is driven by activation of innate immunity, immune exhaustion, and antibody-mediated phenomena. And endothelial cell damage by immune complexes is the primary pathophysiological process in neuro-COVID. And so I want to acknowledge a number of pathologists here who provided us these tissues, and the people who did the work in my lab. These are the people who did all the MRI scanning, and Walter Koshas is the director of our institute.